All right. Hello, everyone, and welcome to the Endocrine Society Science Writers Conference on Obesity Treatments and Heart Health. I'm Colleen Williams, and I'm the Senior Communications Manager here at the Endocrine Society. I just wanted to mention a couple things before we get started here. Everyone's muted today, except our speakers, so we'll take questions at the end following the discussion. You can type in your questions in the chat box. Please just include your name and affiliation. And the webinar is being recorded and will be available on our YouTube channel following the presentation. We really appreciate our obesity experts for being here today, and I'd like to welcome our speakers. We have Dr. Vidya Kadambi of the Medical College of Wisconsin and Dr. Jamie Almondos of UT Southwestern Medical Center. And then we also have Endocrine Society Chief Medical Officer, Dr. Robert Lash here. And he's going to kick off today's discussion with a quick overview of the obesity treatment landscape. And he will also be around at the end to answer any questions that you guys have. So with that, I'll turn it over to Dr. Lash to kick us off.
Thank you, Colleen. And thank you all for attending today. We appreciate having you here to listen to our speakers. Obesity, as all of you know, is an extremely common disorder and is taking an increasing toll on public health. In the past 2 decades, as you can see from the map of the United States on the left, obesity prevalence among adults has increased from about 30% in 2000 to about 42.5% in 2018. And you can also see the geographic distribution of obesity with the darker colored states having higher levels of overweight and obesity. Obesity also takes a greater toll on some racial and ethnic groups, and you can see that in the upper right-hand graph. And not only that, obesity is taking a toll on children, and about 19 to 20% of children also are obese. In addition to the issues regarding obesity and lifestyle, obesity increases risk of developing other serious diseases and health conditions. This includes heart disease, type 2 diabetes, some cancers, breathing problems, joint problems, and gallstones. As experts in hormones and metabolism, endocrinologists play a key role in treating obesity. Endocrinologists evaluate and treat obesity and weight-related conditions, including diabetes. 2 of the drugs that have made a major difference in the treatment of obesity over the past couple of years have been semaglutide and tirzepatide. And these are changing the treatment landscape. It's hard to open a newspaper or a magazine and not be aware of this. These were originally marketed as GLP-1 receptor agonists to treat diabetes. However, their effects on weight loss were significant and observed by both physicians and by patients. The FDA eventually approved a form of semaglutide called Wegovy for weight loss in June of 2021. And yesterday, the FDA approved a version of tirzepatide for weight loss. In addition, so now there are 2 GLP-1 receptor agonists, highly effective ones, approved for obesity. There's also a 3rd drug, liraglutide, marketed as Saxenda. It's been around for about 9 years or so. However, it's significantly less popular and less effective than semaglutide and tirzepatide. Research shows that these latter 2 drugs are quite effective. Semaglutide reduced patients' weight by an average of 15%. And don't forget, half the patients lost more than that. Tirzepatide helped patients lose 22% of their body weight in 1 phase 3 clinical trial. So with that introduction to obesity as a problem and the emerging medical therapies for obesity, I'm going to turn over to our first speaker, Dr. Kadambi, to tell you about obesity and cardiovascular health. Thank you, Vidya.
Thank you, Dr. Lash. So I'm going to start sharing my screen. All right. Everyone can see this okay?
Yep, all set.
Sorry, I'm trying to figure out my... So here we go. So today, my task is to really bring you guys up to date as to how we are doing in terms of cardiovascular outcomes with these novel anti-obesity medications. So these are my disclosures. So I will review relationship between obesity and cardiovascular disease, and some of the new studies that have been published. And also we'll talk a little bit about physiology of these GLP-1 agonists. I think somehow it's moving faster than I want. There must be some auto something, but and then glycemic control with GLP-1 agonists, and also evaluating cardiovascular outcome trials. So as you know, as Dr. Lash already introduced, it's a global epidemic. Obesity is associated with cardiovascular disease risk factors. That's no news. But it's also associated independent of these risk factors. So obesity by itself, without dyslipidemia or hypertension or type 2 diabetes, increases cardiovascular disease and mortality. So this is a study that was published in 2017, looking at global level of obesity. It's not just in developed countries, but all over the world, independent of socio-demographic index, there is increase in, of course, it's higher in high SDI countries, but they're also increasing in every age group across the globe. The panel B shows the prevalence of obesity among children when compared to 1980 to 2015. And panel C shows same data in adults. So it's kind of scary how rapidly it is growing. So in patients with obesity, there is significant prevalence of hypertension. As you can see, 51% of obesity patients with obesity have hypertension. And about 21% suffer from myocardial infarction, and also increased prevalence of heart failure and stroke. So this is a paper that was published in 2018 that shows the hazard ratio, increased hazard of incident cardiovascular disease among individuals with overweight, obesity, and severe obesity in both men and when compared to normal weight. So as you can see, almost the hazard ratio of 3.14 in those with severe obesity when compared to those with normal body weight among men, and about 2.53 in women. So this is scary. And this is also very interesting to actually see what happened over the past few decades. These are the top panels show the disability adjusted life years in 1990 versus 2015. These different colors represent different diseases, all of them linked to obesity, musculoskeletal disorders, cardiovascular disease, cancers, chronic kidney disease, and diabetes, how their prevalence has increased both as cause of death as well as the cause of disability when you look at both panels. So our focus today is on cardiovascular disease, which is in the orange color. As you can see, significant increase attributable to cardiovascular disease, both in terms of disability and death. So this is a busy slide. So when we look at these associations, they are just associations. So as scientists and physicians, we look for biological plausibility. So does it really, is it just an association, or is there a biological pathway to this? So there's definitely a lot of processes that occur in our body when patients, when the body weight increases, that eventually results in atherosclerotic plaque formation that results in ischemic heart disease, which is most often the cause of heart attacks. And heart failure, which can occur independent of ischemic heart disease. You don't have to have blockages in the heart to develop heart failure. So there are many pathways where an individual without any atherosclerotic cardiovascular disease can develop heart failure when they have obesity. Primarily ectopic fat deposition resulting in insulin resistance, impaired autonomic dysfunction, increasing in heart rate, and also resulting in obstructive sleep apnea, and hypertension and liver steatosis, all of which could contribute in one way or the other to heart failure. In addition, obesity is also associated with the cardiac arrhythmias. Again, as you can see, there are multiple mechanisms by which obesity can impact sudden cardiac death or atrial fibrillation. So now coming to the star of our show, incretin analogs. I just want to talk a little bit about incretins. So this I really love this story, how the name incretin come about. So there are studies many decades ago where patients were given glucose intravenously or by intrajejunal gavage. And they've measured blood glucose, and they also measured plasma insulin levels. What they found was that the blood glucose lowering was better when the subjects were given glucose via GI tract versus in IV, and also plasma insulin levels were higher when they gave the glucose through GI tract versus IV. And they did not know what it was. They called it as an incretin effect. And for many decades, nobody knew why giving glucose by a GI tract resulted in more insulin production compared to giving it by IV. So now we know those major incretins are glucagon-like peptide and gastric inhibitory polypeptide, or glucose-dependent insulinotropic peptide, GIP. GLP-1 and GIP, these are produced by cells in our gut. So that was the stimulation that resulted in the glucose through GI tract was the stimulus that resulted in increase in these hormones. Primarily, we talked about previously focused on their effect in glycemia and appetite. So the studies have shown that the postprandial increases in these incretins increases insulin secretion by beta cells, decrease in glucagon, gastric emptying, and increase in satiety, all of which helped with control of blood sugars, as well as eventually it has also helped in weight loss. But we also know that now that they have other metabolic actions, either mediated through weight loss or by direct effects on the cardiovascular tissues. So these are the GLP-1 receptor agonists that are currently in the market. Dr. Lash did talk about a few that have been approved for obesity. But the first once-a-week preparation, exenatide, was approved in 2005. The daily one was approved before that, but I just daily one was approved in 2005, and then the extended release one was in 2012. So the most recent addition is Zepbound, tirzepatide, in 2023. So before we delve into the cardiovascular disease, so these are some of the summaries of the trials. There are a number of trials for each of these drugs, but I just got the one that had the maximum dose of each of these drugs. As you can see, award 11, so that means there are lots of studies before that. And this is the mean reduction based on these trials. So semaglutide and tirzepatide almost result in more than 2% decrease in A1C. And you can also see mean weight reduction when compared to the placebo or the drug that they were comparing it with. So in terms of obesity trials, as we saw, the liraglutide 3 milligram dose, semaglutide 2.4, and tirzepatide 15 milligrams, they showed significant reduction in weight. There are small differences between each of the trials for these drugs, and that is based on the inclusion criteria and things like that. But these are pretty average amounts of weight loss you would see. So these direct, as we mentioned, that there is some direct action cardioprotective effect. There is one receptor. A lot of research is ongoing on this GLP-1 receptor. It's expressed at low levels in heart and blood vessels, and it is a felt that these receptor agonists our work on directly also on cardiovascular system via this receptor. But in general, also decrease in body weight, hypertension, and diabetes also improves cardiac effects. So there have been many cardiovascular outcome trials. I think about 8 in patients with type 2 diabetes. So the common theme of the results of these trials is that they reduce major cardiovascular events. So decrease in non-fatal myocardial infarction, decrease in cardiovascular death, and non-fatal stroke. So if you see that panel below, so there is definitely, compared to standard of care, addition of GLP-1 agonists reduces MACE events. So these are, I only put about 5 of them because among the 8 trials, some of them are not available or not being marketed anymore. So, so these are the trials from which we get our idea about what these drugs do for cardiovascular outcomes. So liraglutide, dulaglutide, and semaglutide have shown positive impact on major adverse cardiovascular events. So there is some difference between them, mainly because of what the exclusion criteria were and also what drugs the patients were on. But in general, they reduced either non-fatal MI or non-fatal stroke and overall cardiovascular death. 2 of the others did not show that they were significant. One thing I do need to point out is that the doses that were used for dulaglutide and semaglutide were lower than what they're approved right now. So maybe there is more improvement, or we don't know, but these are the doses that were tried for those cardiovascular outcomes. So the question you may have is, what about tirzepatide, which was just approved for obesity, but its cardiovascular outcome trials surpass CVOT. Is expected to complete enrollment next year, and results will be reported, starting to get reported in 2025. So right now we don't have cardiovascular outcome data on tirzepatide. So the most recently, this has also created a lot of buzz, where there is results of STEP heart failure preserved ejection fraction, HFpEF, has been reported. So they showed that at the end of 52 weeks, semaglutide improved cardiomyopathy clinical summary score, and also improved body weight in 3 groups of patients that were stratified based on their LV ejection fraction. Note that these are not low ejection fractions. They are maybe low normalish to very good ejection fraction. So these patients mostly suffer from what we used to call diastolic dysfunction. They would have heart failure, mainly because of effects related to obesity. So they found that they improved. So now what about the HFrEF? I put a lot on this slide because I feel like I have to justify myself now if I say anything bad about these drugs, or not bad, or even say something not flattering. So in terms of heart failure, you saw that MACE events does not include heart failure. So those cardiovascular outcomes trials did not show improvement in heart failure, or did not show improvement in patients with reduced ejection fraction. So the HFpEF trial, STEP HFpEF, was those with the preserved ejection fraction. So a couple of trials that were done in patients with reduced ejection fraction, or HFrEF, failed to show any improvement, and there was some slight deterioration in patients who had heart failure due to reduced ejection fraction. So right now, the recommendation for those with the reduced ejection fraction is that maybe used with caution or avoid it. So the reason is possibly that GLP-1 receptor agonists increase heart rate, and that might not be beneficial to these individuals with severe decrease in left ventricular dysfunction. We do see increase in heart rate in most people who are started on these drugs, but most people, it is okay. If they're living at 70s, now they may live at 80s. It doesn't really make a lot of difference in a person who doesn't have underlying heart failure. So at least, that is the thinking that why they may not be as beneficial or did not show benefit in heart failure. So until further investigation is done in these individuals with advanced heart failure, so caution is recommended. So obviously the adverse events are important part of the conversation of these drugs. And again, they're very, very individualistic and also very based on the medication that's being used, based whether it is semaglutide versus tirzepatide or liraglutide. So again, it's very individualized. So these are the things that we would like to keep an eye on: nausea, vomiting, diarrhea, sometimes constipation even, and hypoglycemia if they're using insulin, and of course pancreatitis, and theoretical concern about malignant thyroid C-cell tumors. So with that, I am going to stop sharing.
Great. Thank you, Dr. Kadambi. We'll go ahead and turn it over to Dr. Almondos to present.
Hi there, everyone. Let me just share my screen for you. All right. I will assume that you can see it unless I hear otherwise. So I get to follow Dr. Kadambi, and it's quite a tough act to follow because everyone seems to be talking about GLP-1 agents for facilitating weight loss and for treating obesity. And it's almost like I feel that we're in this GLP-1 or bust era for treating obesity. And what I want to do is provide the counterpoint to accessible therapies that are covered by more insurance plans and that may, in fact, have a better evidence base for treating obesity and its related complications. So here are my conflicts. So we're going to go over kind of the role of bariatric surgery for treating obesity, the effectiveness of surgery for treating cardiometabolic disease, including fatty liver and type 2 diabetes, and then also look at the impact of bariatric surgery on risk for cardiovascular events, cancer, and mortality. So it's not a talk about obesity unless you see one of these heat maps, and Dr. Lash went through one of these before. But if we focus in on the right-hand side, I think rather than looking at prevalence of obesity across the country, looking at the increase in the prevalence of obesity over the last 2 decades, we see that the prevalence of obesity, BMI 30 or greater, has gone from 30% to over 42% in the last 2 decades. And if we look at severe obesity, this is class 3 obesity or those with a BMI of 40 or greater who qualify for bariatric surgery, we can see that the rates have almost doubled in the last 20 years too. So in spite of all of our efforts, rates of obesity and severe obesity are on the rise. But what do we do about it? So bariatric surgery has been around for many decades, and there's been an evolution in terms of the outcomes and in terms of the effectiveness of bariatric surgery. There are now centers of excellence for bariatric surgery. And whereas maybe 20, 30 years ago, rates of complications were relatively high, now with training and advanced laparoscopic methods for performing bariatric surgery, it's comparable to having a gallbladder surgery in terms of perioperative risk. If we look at the criteria for bariatric surgery, these are the 1991 NIH criteria for bariatric surgery, which is what's covered by Medicare and most payers in this country. You can undergo surgery with a BMI of 40 or greater, or a BMI of 35 to 39 with one obesity or weight-related complication or comorbidity, such as elevated blood sugars, sleep apnea, fatty liver, etc. When we look at procedures that are performed in the US, about 70% are sleeve gastrectomies or gastric sleeve surgery, where average weight loss is around 20 to 25% with this procedure. The next most common, about 25% of surgery, is the Roux-en-Y gastric bypass. And we see the kind of outcomes with regards to weight reduction about 25 to 35% at 1 to 2 years after surgery. Much less common and kind of an older procedure is the adjustable gastric banding, which really isn't done very much, around 15% weight reduction. And then a minority of surgeries is this more complex biliopancreatic diversion with duodenal switch, in which people lose about a third of their body weight or more. The question is, how much weight do people need to lose in order to be healthy? If we're looking at improvements in things like blood sugars or triglycerides, or if we're looking at kind of patient-reported outcomes of improvement in quality of life, let's say related to their weight and how it impacts their life, we need only about 3 to 5% weight loss in order for that to happen. If we're looking at kind of harder outcomes, so for example, somebody has fatty liver disease and inflammation, we're looking at liver biopsies, or they have sleep apnea and we're looking for a meaningful reduction in terms of how many times they stop breathing per hour, we're really looking at 10% weight loss or more. However, if we're looking for kind of harder outcomes in terms of cardiometabolic disease remission, trying to get rid of their diabetes, for example, decreasing the risk of heart attack and stroke, we're really talking this kind of 15% or more weight loss. And that's not easy. Eat less, move more really is not very helpful for facilitating this magnitude of weight loss. And if we look at this figure where what we have here on the y-axis is weight loss percent, and then what we have here are anti-obesity medication therapies. If we look at lifestyle modification, so that's kind of the house wine, if you will, for treating obesity of, hey, why don't you cut back on your calories and exercise some more? We're really looking at a non-sustained reduction in body weight of somewhere between like 3 to 7%. If we're talking about bariatric surgery, we kind of touched on that in the last slide, we're really looking at kind of a 20 to 35% weight reduction with the sleeve and the Roux-en-Y gastric bypass. Older generations of anti-obesity medications were somewhere in the 5 to 10% effectiveness range for decreasing weight. But now we have the second or next generation of anti-obesity medication therapies that Dr. Kidambi talked about. So we've got semaglutide 2.4 milligrams, and then the recently approved, I need to update this slide as of yesterday, I apologize, the recently approved tirzepatide for treating obesity. We can see that we're really kind of bridging this gap between lifestyle and bariatric surgery. But you can't look at your social media or your news outlets without hearing of the lack of affordability, access, and coverage, or even the supply chain issues related to these very effective medications. But what about bariatric surgery for treating obesity? So we're going to start by looking at bariatric surgery for treating fatty liver disease or metabolic associated steatotic liver disease, okay? This year saw the release of the first ever randomized controlled trial for bariatric surgery for treating fatty liver disease or steatohepatitis. It was called the BRAVES trial. And what we can see on the left-hand part of this slide is that we saw remission in the steatohepatitis without worsening of fibrosis or scarring in the liver in approximately 56 to 57% of people who underwent bariatric surgery. And we saw improvements in at least one stage of fibrosis in more than a third, close to 40% of people who underwent bariatric surgery. Now, there are currently no approved medications for treating fatty liver disease, but this surgery appears to be incredibly effective for inducing, let's call it remission or resolution in fatty liver disease in more than 50% of people who undergo surgery. I like to show this older French study for bariatric surgery in people with biopsy-proven steatohepatitis, so severe fatty liver disease, because what it demonstrates is the dose-response relationship between weight loss or weight reduction on the left-hand side here by 5 to 10, and more than 10 BMI points, showing that those who lost more than 10 BMI points as a result of bariatric surgery, more than 90% of them had a resolution in their fatty liver inflammation. What it also shows on the right is that time, so we lose the weight, but also time since the surgery also improves. F0 is the white bar here at the bottom. We can see F0 or no evidence of fibrosis. We can see the proportion of people with that increases at 1 and 5 years following surgery. So the magnitude of weight loss after bariatric surgery is important for inducing disease remission, for getting rid of those complications. But beyond that, if we look at bariatric surgery, not just for kind of on the biopsy improving things, what we want to do is look at how does this impact outcomes for people with fatty liver disease. And so what this is a composite outcome for progression to clinical or histological cirrhosis and development of hepatocellular carcinoma. So that's a cancer that's a complication of fatty liver disease, or the need for liver transplant or liver-related death. If we compare people who underwent bariatric surgery versus those who did not undergo bariatric surgery, that's the control group, there was an 88% reduction in this composite of bad liver outcomes for people who underwent bariatric surgery. Now, we don't have a medical therapy or a lifestyle or a diet or an exercise program that can make this kind of health improvement for people with the disease state. So I just want to highlight how effective bariatric surgery can be, not just of improving things under a microscope, but actually improving the outcomes for people with fatty liver disease. We're going to change gears and look at bariatric surgery for treating type 2 diabetes. So this is a composite of two different randomized controlled trials for treating type 2 diabetes or people with type 2 diabetes with bariatric surgery. And there are three different procedures that are being evaluated here. So if we look at the left-hand side of the slide first, this is a proportion of people who had type 2 diabetes when they underwent surgery, who were still in remission, so no longer had diabetes 5 years after undergoing surgery. And what we see here is in the gray, we've got sleeve gastrectomy. In the blues, people who underwent gastric bypass. And in the kind of orangey bar, this is the biliopancreatic diversion group. And so what we can see is that 5 years after surgery, about a quarter of people who underwent gastric sleeve surgery still didn't have their diabetes back. They were in remission. More than let's say about 31 to 37% of people who had gastric bypass, they still didn't have their diabetes, and almost 2/3 of people who underwent biliopancreatic diversion were still in remission from a diabetes perspective. So you might be saying, well, that means some people got diabetes back. Well, they did, but let's look at the right-hand side, and these are changes in the hemoglobin A1C, so the marker of diabetes control. And what we see here is that with the sleeve gastrectomy and room-wide gastric bypass, we see reductions in hemoglobin A1C of about 2 points and about 2.5 points with the biliopancreatic diversion. Until recently, we really didn't have medications that weren't insulin that caused this magnitude of reduction in A1C and improvement in glycemic control. So I just want to highlight that, even in this is the change in A1C at 5 years. So even though people got back their diabetes, we can see that the A1C was significantly better after they had surgery, even 5 years out from it. If we look even further out at 10 years out of bariatric surgery, we can see that people in the study, and if we look at the graph on the left-hand side of the slide, the average A1C was somewhere between around, say, 8.5%. So that's kind of uncontrolled diabetes, let's say, for the most part. And when we kind of look at the changes in hemoglobin A1C after bariatric surgery, we can see that although by year 5, there is an increase in bariatric surgery, they're still under this kind of control line of 7%. And so even though there's a recurrence in diabetes, it appears to be much better controlled, or one could say easier to manage. Beyond blood sugar control, let's look at complications, because one of the main reasons why we care about controlling blood sugars, apart from keeping symptoms controlled for people with diabetes, is to decrease their risk of complications from their diabetes. And what this nicely shows here in this figure on the right of the slide is that for those who underwent surgery, and that's the bars on the right, versus those who underwent medical therapy, so the control group on the left, we can see that there's substantial difference between those who developed microvascular complications, so think eyes, kidneys, and nerve complications, 61% in those who were medically managed, so in the non-surgery group, versus only 5% in those who underwent bariatric surgery. And if we compare those who had macrovascular complications, so think heart attack, stroke, and peripheral arterial disease, 11% in the medical therapy group, and I can't even see a bar in the surgical procedure group. So all this to say is that bariatric surgery is quite effective for inducing remission in diabetes, so putting the disease to sleep for a while, in terms of decreasing blood glucose or controlling diabetes, and also in terms of decreasing complications as a result of having type 2 diabetes. There are certain things that go into, well, who is likely to experience remission in their diabetes after bariatric surgery. And what this figure on the left here does is break down, these are the likelihood ratios of experiencing remission in diabetes. And for people who aren't on insulin, we can see that you need to lose at least 10% of your body weight in order to have a statistically significant chance of inducing remission in your diabetes. But for those who are on insulin, we can see that they need to lose 20% or more in order to do the same thing. And so all this to say is that diabetes is a very complex chronic disease, and that there are certain factors which may make people more likely to experience remission in their diabetes after bariatric surgery. And we need to incorporate that into the discussions with our patients, because what this appears to show is that if you are earlier in the course of your disease, so if we look here on the right, if we look at predictors, we see weight loss, which is what we can see in the figure here. Other predictors of remission include shorter history of diabetes, good preoperative blood sugar control, not being on insulin, younger age, smaller waist circumference. So all these factors make it more likely that you'll experience remission in your diabetes. Here's the thing. Oftentimes, both patients and providers wait until diabetes is quite advanced before they even have the conversation about weight loss and even about bariatric surgery. So what this suggests that if we intervene earlier in the course of the disease when it is less severe and less advanced, we actually have a higher rate of causing remission in the diabetes. And so maybe we need to have an earlier conversation about how to treat obesity. In acknowledgement of these data around bariatric surgery, the American Diabetes Association standards of care for this year actually incorporate bariatric surgery, saying that it should be recommended to treat diabetes in adults with a BMI of 35 to 39 who have not been able to achieve durable weight loss. And they also suggest that it can be considered as a treatment option for those who don't have durable weight loss in BMI 30 to 35. So I think this is a supporting document that shows the utility of bariatric surgery in people with type 2 diabetes. Let's talk briefly about bariatric surgery and cardiovascular disease. So we saw the slide earlier showing the decrease in liver outcomes or negative bad liver outcomes in people with biopsy-proven steatohepatitis. We know that people who have fatty liver disease are at increased risk for things like type 2 diabetes and also cardiovascular disease. What this same study, the Splendor study, shows is that for people who underwent bariatric surgery who had biopsy-proven fatty liver disease versus those who were non-surgical or non-surgical controls who didn't undergo bariatric surgery, there was a 70% reduction in cardiovascular events in people with fatty liver disease who underwent bariatric surgery relative to those who didn't. That's a 70% reduction in cardiovascular events and disease. Now, it's really hard to get that with medication therapy. And so I just want to highlight here that people with fatty liver and other complications of obesity are at increased risk for cardiovascular disease. And what we need to do is think about how we're going to treat their obesity and their risk factors beyond just trying to treat their fatty liver, because we're treating people, we're not treating diseases in isolation. This year at the American Diabetes Association meeting was the release of the Swedish obesity study. That's one of the longest running cohort studies for bariatric surgery that we have to date. And this showed the cardiovascular mortality 30 years out from surgery. And they broke it down by the presence of type 2 diabetes. And what it shows is that for those with a history of type 2 diabetes, there was a 35% reduction in cardiovascular mortality 30 years out from surgery. And for those without type 2 diabetes, there was a 30% reduction in cardiovascular mortality 30 years out from surgery. So there's a nice durable effect of bariatric surgery on decreasing cardiovascular disease risk in people with and without bariatric surgery as far as 30 years out, okay? When we look at people who have existing cardiovascular disease, and Dr. Bond touched on the SELECT trial, which is the semaglutide study, looking at people with a history of cardiovascular disease who are treated with semaglutide 2.4 milligrams, they saw a 20% reduction in cardiovascular events. What this shows is that for people who undergo bariatric surgery who have a history of cardiovascular disease, there's a 50% reduction in all-cause mortality, a 65% reduction in cardiovascular mortality. There's significant reductions in coronary artery events, decrease in heart attack, decrease in heart failure hospitalization. So even for people who have existing cardiovascular disease, there is a benefit to them undergoing bariatric surgery and treating their obesity. And I just want to highlight that this is not just about bariatric surgery to cause weight loss. This is about the multitude of effects that happen when we treat obesity as a disease with highly effective therapies such as surgery. Not to do too much of a hard sell, I just want to highlight the impact of bariatric surgery on decreasing cancer risk. And so on the left-hand side of this figure, we can see a nice dose-response relationship in reduction of obesity-associated cancer cases. So think kind of breast, colon, uterus type cancers, those that are associated with excess body fat. We can see that if you divide weight loss by quartiles, we can see that there's a nice dose-response relationship between body weight reduction and reduction in obesity-associated cancer risk in people. If we look at the right-hand side, this is cancer-related mortality, we can see that for people who undergo bariatric surgery, relative to those who don't undergo bariatric surgery, there's about a 50% reduction in cancer mortality in those who underwent bariatric surgery. So when we talk about kind of the impact of bariatric surgery, not just on mortality and life expectancy in general, I'll talk through this figure, which is a little bit busy. What we have here is a reference group in the purple bar on the far right. And these are people who do not have obesity, okay? And what we have is the surgical group to the far left, and then the control group in the middle. And what this says is that for people who undergo bariatric surgery relative to matched controls with a history of obesity, those who undergo surgery increase their life expectancy by about 3 years relative to the control group. So bariatric surgery appears to increase life expectancy relative to people with obesity who don't undergo bariatric surgery by about 3 years. However, relative to those who have not lived with obesity, people with obesity, even if they undergo bariatric surgery, still live about 5.5 years less. So what this says is that bariatric surgery improves life expectancy for people with obesity, but does not normalize it to the point that as if they had not lived with obesity before. So I want to wrap up by just kind of highlighting that as endocrinologists, we treat chronic diseases every day, such as type 2 diabetes, thyroid conditions, et cetera. And obesity is one of the diseases we also treat, and we treat it very well. What we need to do as clinicians is make sure that there aren't secondary or other causes that we need to address as part of this, and come up with really an integrated plan, not just for weight management, but also for treating the obesity-related complications through a mixture of nutrition, activity, and behavioral interventions that are both practical, individualized, and sustainable. We need to consider whether we need augmented tools to help people to achieve these clinically meaningful cut points for weight reduction, which can include pharmacotherapy or bariatric procedures like we just talked about today. Sometimes this gets presented in a linear fashion that we'll try lifestyle first. If that doesn't work, we'll try medications. If that doesn't work, we'll try surgery. What I want to socialize here is sometimes we might need to go straight to surgery instead of going through medications first, because it may be the most effective and evidence-based treatment for the person in the office in front of you. I want to highlight that neither pharmacotherapy nor bariatric procedures are curative for obesity and need to be done as part of an integrated lifestyle plan. But that once someone has undergone pharmacotherapy, there may still be a role for bariatric procedures in helping to optimize body weight and to control body weight long term. And likewise, for those who've undergone bariatric surgery, there's also a role for pharmacotherapy in terms of treating insufficient weight loss or weight recurrence after bariatric surgery. And so I'd like to wrap this up with a nice summary here, saying that bariatric surgery is safe, effective, and unfortunately underutilized for treating obesity and its complications. Less than 1% of eligible Americans undergo bariatric surgery for treating their obesity. Weight loss of 15% or greater is often recommended and desired by patients, but lifestyle modification and until recently medications are unlikely to help people to achieve this goal. We need to make sure we're giving people evidence-based tools for achieving their health goals. Bariatric surgery can effectively treat complications like type 2 diabetes and fatty liver disease, and greater weight loss leads to greater remission in select groups. And finally, in addition to atherosclerotic cardiovascular disease risk reduction, bariatric surgery may decrease cancer risk and increase life expectancy for people with obesity. And with that, I'd like to thank you for your attention and be happy to take questions.
Great. Thank you so much to both of our speakers today. We're going to open up the Q&A. Again, we just ask if you could please include your name and outlet in the chat window. And with that, I'm also going to turn it over to our Director of Communications and Media Relations, Jenny Glenn-Gingrey, and she's going to assist with the Q&A portion.
Hi, Colleen. We don't have any questions yet in the chat window.
Okay. Pull that up. I have a couple of questions here just to kick us off. The first one is for Dr. Kadambi. Do you think we'll continue to see a decline in heart health issues with the advent of these new anti-obesity medications?
That's a great question. We were chatting before. So the number of people that are at risk for heart disease and compared to how many people receive the medication, it's, we are nowhere close to addressing the risk of obesity in everyone. Now, there is background risk of cardiovascular disease, right? Based on age, gender, many other risk factors, smoking and things like that. So, but if we can bring the weight down, so some of that risk can be alleviated, definitely. But to see in terms of we are a long ways to go because these drugs have been around just for a short period of time. Cardiovascular disease starts in childhood. So there is over the course of the years, so we need to address a lot of these things before we start seeing on a map, there is decrease in cardiovascular disease, but there is hope.
Great, thank you so much. I think we have a question in the chat, or a couple questions.
Yes, thank you. We have a question from Mike Monastra from Helio Endocrine Today. Is there a concern that some providers may jump right to medications for treating obesity without considering other options, such as bariatric surgery or lifestyle intervention, especially with yesterday's approval of tirzepatide? Do we need new recommendations to help guide providers?
So I can start answering that. The way I look at kind of let's say obesity treatment, it's something we really haven't normalized the way we have other chronic diseases. So say, for example, maybe 30, 40 years ago, we may have approached cholesterol management with strict lifestyle, talking about low saturated fat diet, and really focused in on that because there weren't many effective or affordable medications for treating this. Whereas now we're in an era where we have highly effective medications, and don't mishear me, I'm not saying that lifestyle is dead. I think it's important to incorporate these factors, but the role of lifestyle in terms of seeing the successful weight reduction may not still be there. I think given the effectiveness of these medications, what we need is to make sure that people receive appropriate nutrition and physical activity guidance to avoid potential complications. Unfortunately, in general, the quality of the North American diet is not great. And with these medications that induce satiety, so we feel full earlier, we may have people who are then just eating less of a low quality diet, which will exponentially increase the risk of malnutrition. If it's low protein, there may be increased risk of lean mass or muscle loss, especially if they're not being physically active. So what we need to do is identify high risk groups and people in general who would benefit from individualized nutrition counseling, physical activity recommendations, especially older adults, to make sure that we are not unfortunately making people sicker in the process of trying to make them healthier, and which is why I kind of emphasize it. This is really about treating obesity. This is not about weight loss. It's about optimizing health and quality of life, and we need to make sure we don't lose sight of that.
Thank you. Dr. Kadambi, Dr. Lash, do you want to weigh in here?
I completely agree. We have to use everything together. So often, maybe it is a little bit a biased group of people that I see, and if Dr. Almando sees, is that often patients come to us after trying everything, because this is not a secret. I mean, the idea about healthy diet and weight and exercise are out there, and a lot of people have already tried on their own to their best extent. So I think it's not, we are, when we see patients, I think we see what stage they're at. If someone has absolutely done nothing, yes, medications and surgery discussions are probably, 3 or 4 months down the road. But if most often people we see are that, they know that they have tried all of these things, and it's biologically, they were not able to either lose weight or keep it off. So I think they need to go hand in hand together at the same time.
Great, thank you. We have a question from Sophie Putka from MedPage Today for Dr. Albandas. Why is bariatric surgery so underutilized?
Oh, I think there's multiple layers to this. I think we can start with kind of the history of bariatric surgery, something that may have had kind of higher complications maybe 20, 30 years ago. And I think that lives with many people when we bring up the conversation around surgery in the clinic. It may be, I know somebody who had a bad bariatric outcome. And I think these stories stick in their minds because I think we all know someone who's had bariatric surgery who may have had a negative outcome, may have experienced significant weight recurrence, or unfortunately a complication related to malnutrition. And so I think, helping people to understand that there have been significant advances both in the training, the requirement for training, centers of excellence accreditation, and also the techniques for surgery is that the surgeries are much better. We know more now with regards to what's needed in terms of preoperative education, postoperative nutrition, counseling, supplements, monitoring, and follow-up that can really help people to optimize their health and to decrease this. I think there's also an element of weight bias and stigma in society around what causes obesity and a misunderstanding that it's a very complex disease. And while being in a positive energy balance may help us to accrue extra fat, you can't put the car in reverse and just lose fat and empty your fat cells out. There's a lot of complex neurohormonal changes that occur as a result of accruing or developing obesity that you can't just put the toothpaste back in the tube by eating less and moving more. And I think that is unfortunately a misunderstanding both throughout the general public, but also within certain sectors of the healthcare community where well-intentioned providers will tell patients that all they need to do is eat less and move more. And really, we can see that this is not effective for treating obesity and the epidemic of obesity, and we need to use evidence-based therapies.
Great, thank you. For both Dr. Almenda's and Dr. Kadambi, we have a question from Miriam Tucker, who's a writer for Medscape. Assuming insurance coverage availability for Zepbound and Wegovy, how would you go about evaluating the pros and cons of those drugs versus surgery for a given patient? What characteristics might lead you to consider surgery first?
I can start that, and Jamie can chime in. So if the patient has criteria that are covered for approved for bariatric surgery, BMI over 40, and also comorbid conditions over 35, I definitely bring it up. So that's first one that for surgery. Because there are lots of options, and surgery is definitely, sometimes the primary care doctors or the referring doctor kind of beat around the bush because, oh my God, I'm going to suggest surgery, what am I? So, but I think explaining that, the amount of weight that someone needs to lose to achieve their goal probably is not doable by at least the medications that we had until a year ago or so. So I think that's first discussion I would have if they qualify an amount of weight to lose. The other criteria that I use is also young, relatively healthy individuals with no other comorbid conditions. So the way I approach is that, we now know that we probably are not going to stop the obesity medications. This is like hypertension or diabetes. So what we know is that if we stop the medication, the weight comes back. So when I see a 20-year-old or 22, 25-year-old, am I ready to commit someone to lifelong therapy? Or is it bariatric surgery a better option in those cases? Yes, you need to take vitamins and there are other things that you need to follow. But I think the cost of medication as they stand right now, and the number of years and lack of, these drugs some of them have not been around that long. So am I committing a 20, 25-year-old for next 20, 30, 40, 50 years of therapy? So I tend to use that as one of the reasons to recommend bariatric surgery in some patients.
Jamie, go ahead, Jamie. I'm sorry.
No, sorry. Thanks, Dr. Lash. I was just going to kind of chime in that, I would love to live in this kind of fantasy world where everything is covered by insurance. I think this is really challenging, though, when, Medicare does not cover any anti-obesity medications but does cover bariatric surgery, which is why I wanted to kind of provide today's counterpoint with regards to there are great medical therapies, but also there are great surgical therapies for treating obesity. I think I just wanted to highlight that obesity is a chronic disease, and Dr. Kadambi touched on that medications will be continued indefinitely, but There's also a lot of heterogeneity in terms of how much weight people lose after bariatric surgery, and weight recurrence is very common too. And so I don't like to look at this in a binary world of this or this and how do we decide. It's a what sequence and what combination is going to be best for that person in the room. It may be that they undergo bariatric surgery and have a history of cardiovascular disease, and they may benefit from having an incretin-based therapy on for additional cardiovascular risk reduction long-term beyond the weight maintenance. And so I think that highlights the importance of both chronic therapy, but also individualizing care to the person in the room.
Great. Dr. Lash, did you have anything you wanted to add?
Well, I was going to ask a question of Jamie, and he actually touched on it. Most people who have bariatric surgery, they lose a significant amount of weight, but they don't lose all their excess body weight. And so how common do you think it's going to be to mix and match, leaving aside cardiovascular risk aside, that somebody has bariatric surgery, comes back 3 years later and says, you know what? I'm not where I want to be, and I'm not, and could we add on a little bit of one of the new medications?
Absolutely. I think, there's several points maybe buried in your question there with regards to the effectiveness of bariatric surgery in terms of treating obesity and reducing BMI. But I just wanted to highlight the goal of treating obesity is not to have a BMI of 25 or less. It's about how we are improving health and quality of life, and that does correlate with weight reduction. So not to be too much of a politician, I'll answer your question. I think, yes, there's clearly a role for integration of therapies for treating what is termed insufficient weight loss after bariatric surgery, because there is still both a correlation between achieving and maintaining the weight reduction after bariatric surgery with quality of life and health outcomes. So I think definitely this is going to be something that is used more frequently, especially as we see a greater prevalence of severe obesity or class 3 or BMI even higher, where what we're trying to do is help people to achieve their goals. It will likely not just be one treatment modality.
Great, thank you. We have a question from Emily Mullen from Wired for Dr. Kadambi. Does weight loss explain all the benefits of semaglutide for cardiovascular problems, or is there some other mechanism at play?
Definitely. As I mentioned in my talk, there seems to be GLP-1 receptors on, even though low concentrations, but they are present on heart and vascular tissue. So not all benefits, at least as far as we know, is from weight reduction. Indirectly, the weight reduction also helps improvement in dyslipidemia, type 2 diabetes, obstructive sleep apnea, which are all risk factors for hypertension. So there is some benefit in that way. Direct effects of weight reduction as well as direct effects seem to be occurring on the receptors itself on the heart as well as vasculature.
Great, thank you. We have a question from Karen Weintraub from USA Today. She asks, could you please summarize your thoughts on the SELECT trial? I believe Novo Nordisk has announced they're going to be presenting more data this weekend on that. Do you think that semaglutide makes sense now for people with existing heart disease?
I can start quickly. So the SELECT trial, an event-driven trial, 17,500 people who had pre-existing cardiovascular disease. So about 3/4 of them had prior MI, 1/4 of them had prior stroke, and maybe 9% had prior peripheral arterial disease. And so I want to make sure we just kind of socialize ourselves to the idea of what's the population that's being studied. These are people without a history of diabetes. About 2/3 had pre-diabetes. Because what I think it's important is to look at the population so that we don't overinterpret or over-extrapolate the data that's there. This is not that we can just prescribe this to someone without a history of diabetes and say, well, we're going to decrease their cardiovascular risk by X or Y%. This was a specific patient population in whom this was demonstrated. That being said, we can maybe infer that treating obesity will improve long-term cardiometabolic outcomes, quality of life, biomechanical complications, and cancer risk of obesity. So all that to say, to kind of get to your question, do you think semaglutide makes sense now for people with existing heart disease? Looking at the SELECT HFpEF trial, that's, patient-reported improvements in symptoms related to their heart failure in people who've lost 30+ pounds. So that, if we lose 30+ pounds, we're going to have an improvement in a lot of different symptoms. When we look at this, I would say, yes, it does make sense to consider semaglutide in people with cardiovascular disease because this is where we have the most evidence currently. But also we need to think about, well, what is most appropriate for the patient in terms of magnitude of weight reduction needed and which agent or intervention, be it bariatric surgery or another procedure or lifestyle intervention, is most likely to help them achieve that.
If I could just add to that, I completely agree with what Jamie said, but every time there's a new drug that appears to reduce cardiovascular risk, it's like the shiny brass ring that everybody wants to grab. There are a number of other incredibly effective medications that reduce cardiovascular risk, controlling blood pressure, taking statins, stopping smoking. I mean, just because there's a new drug in 2023 that reduces risk doesn't mean all the things we learned prior to 2023 are obsolete and not worth of considering. Managing cardiovascular risk is a multifactorial process. And I think it's really important to keep in mind that what's new is not always what's best.
Great. Dr. Kadambi, do you have anything to add?
No, I think I echo everything. There are many other things that we need to do. Yes, this is one tool in the toolbox. So there are some people, yes, that we need to. Otherwise, but there are also, real risks of side effects, cost of therapy that's, associated with that. So I think all and everything that's appropriate.
I just wanted to answer kind of Karen's subsequent question there about select trial. Yes, people in this study were already on kind of standard of care for people with existing cardiovascular disease, be that kind of blood pressure control, statin therapy, or antiplatelet therapies as well. So you are correct, yes. And so what this demonstrates is, in addition to standard of care, including statins, there was a further 20% reduction in a composite of cardiovascular endpoint for these people.
Great, thank you. We have one more question from Emily Mullen at Wired. She asks about the speakers, are GLP-1 drugs poised to be the next statins?
I can start then. I'm biased. I would say, it all depends what you mean, but I think that they're probably better than statins, because statins decrease cholesterol, cardiovascular events. We believe that they're kind of pleiotropic, kind of anti-inflammatory, and some other properties. But what we're looking at is a class of medications that are helping to improve a multitude of health outcomes. We really don't have great quality of life data with regards to statin therapy the way that we do with regards to obesity treatment and disease prevention that spans, or treatment that spans, cardiometabolic outcomes such as diabetes, blood pressure, and a whole host of other things too. And so I think there's so many more studies looking at the potential benefits of these medications, even for improving our relationship with alcohol and substance use disorders, that I think what we're seeing is that there are perhaps many more effects with this class of drugs than what we see with statins in terms of potentially improving the health and quality of life of people.
I think I would like to use in a lot more patients than right now that we are able to use. I think it's a fair point to say that, they could be like statins or, in my view, also metformin or some of these drugs based on tolerability. And so the cost is going to be one big thing in the question. And also number of years, many of these drugs have been around, so that at least the newer ones, the most effective ones, not been around for longer than 10 years at least. So I think that we need to keep in mind as to if there is some long-term effects, all of those things need to be kept in mind before their next statins. But I agree with Jamie, but they are really changing lives of many, many patients in terms of reducing the weight and improving quality of life.
Thank you to both. That's all the questions we have in the queue.
Great, thank you so much. Those were awesome questions. And if anyone has any follow-up questions, you guys can feel free to reach out to us at media@endocrine.org. And as a reminder, this will be up on our YouTube channel following the discussion. So thank you again to all of our speakers and to everyone for joining today. And I hope you have a great rest of your day.
Thank you.
Thank you very much. Thank you for joining us.